back in. Is that working now? Seems to be. Yep. All right. Sorry about that, guys. So this is Charles. I'm one of the surgeons at the Animal Emergency Center in Moorabbin. We've got a Rottweiler, 9 years old, with a history of collapse last night. On abdominal ultrasound, they found a lot of fluid. And so on analysis of the fluid, he's got septic peritonitis. We don't know what the cause of that septic peritonitis is. He has been on meloxicam long term. So my assumption is that he's got a perforated duodenal ulcer. I beg your pardon? Yeah. Now he might be getting a little bit light. And just keep moving that in and out, please. He doesn't have he doesn't have any pain relief, so we may need to get him either on a CRI or give him some methadone. Probably. I beg your pardon? Let's get fentanyl going. So that momentum is looking pretty nasty. He's already hypoproteinemic. Now I can't see the question box because the streamer is not set to it, so I won't be able to answer questions for the time being. It's probably good that I'm not distracted anyway. That's all nasty momentum there. Try to tuck that back in. And that looks like a very inflamed, unhappy abdomen.
You need some literature?
I've got the handpiece over there. I don't need it yet. Oops. All right, let's get our balfours. So Ruptured hepatic abscess would be another possibility. Perforated intestine, intestinal foreign body, ruptured prostatic abscess, although he's a neutered male, so that would make that very unlikely. How are we doing on fluid? Good. Hi, Helen. So we're just having somebody from the emergency center popping their head in to help us out. So I'm just trying to get all of this pus out of the abdomen before we can... yeah, so it's a 9-year-old Roddy. Collapsed yesterday, was doing well until yesterday. Collapsed acutely. They found septic peritonitis on abdominal tap. His white cell count is 45,000 with band. His albumin is 18. He's got just a very angry belly. I'm presuming best guess is a perforated duodenal ulcer or something, because he's been on Mobic his whole life. Been on meloxicam his whole life without any gastric protectant. So that's my working diagnosis. But until we get in there, get a better look around. He's got gas in his stomach, which means that it's probably not the stomach that's perforated. Things are looking kind of funny up here in the antrum. To place an O-tube? Yeah. Yeah. I had thought about putting in a gastrostomy tube, but just with the peritonitis, Kate was worried about dehiscence or whatever, yeah. Okay, yeah, happy to. All right, so we'll try to run the bowel now. So the stomach looks intact. I guess the other thing could be a GDV that's perforated, but that's not. I mean, the stomach looks nice and healthy. So let me get down into the duodenum. Thank you. So I can feel a kidney. Haven't been able to find the duodenum yet. So gallbladder, easily expressible. Can I ask you a favor? Can you go over to the streamer? And there's on the bottom, you see a speaker that's in red. On the bottom right of the screen. Go over to the right now. Is that other screen? Yep. All right, so you see a red speaker. Click on the white quotation bubble. Yep. Great, thanks. All right, so I've got jejunum here. Trying to find duodenum. So I've got duodenum here, and I see a perforated ulcer right there. Okay, well there's your answer. I might, let's just see here. So I've got a little hole right here in the duodenum, right there. I don't know if you guys can see that. Right there, I don't know, it's probably just out of your view. So the dog does have hypoalbuminemia, and we are going to start a plasma transfusion if we haven't already started it. So just get all the guts out here. And I am going to run the bowel quickly before I repair that duodenal ulcer perforation. Having a little difficulty making it around the corner. So so we'll just run the bowel in the other direction first. So those intestines look very, very unhappy. Cecum there. Let's get some saline on that. Okay, so that's the caudal duodenal flexure right there. Can we get some 3-OPDS and some extra hemostats, please? Yes, please. It is hypoalbuminemic at 18. And so, yeah. I think I just said that. All right, so spleen is nice and small, and that's because it's kind of shocky, and so so I can see the adrenal gland, that's normal in size. All right, so what we'll do is we'll just keep that nice and moist. Let's get a, okay, so we're leaking some bile up here. Now I'm going to have to try to exteriorize this a bit. Without tearing it. Now there's some little bit, can I get a ligashore, please? Yep. Thank you. So there's some bands here that I'm going to release. So I can exteriorize that part of the, and I just have to be careful not to get the common bile duct. So you know what, let's just grab another, hold off on that for a minute. Okay, so just retract on that for me, please.
Yeah, retract it here.
I beg your pardon? Okay. All right, so you can kind of see the perforation right there. All right, so what I need to do is get a stay suture on that. Hemostat, please. Come around this side, please, Brian. Yep. Retract on that gently. And then we'll try to, can we get some more lap sponges, please? Yeah. I'm going to get you to retract on that a little bit more aggressively. So we've got 5 more lap sponges, D. 1, 2, 3, 4, 5. I'm just trying to pack this off so as to prevent some contamination. All right, now. I'm trying to resect a bit of this and freshen the edges. Now, just to note that because this is such a critical patient, if things start going pear-shaped, we are going to stop the live stream. And I'm just opening it up a little bit so I can see what's going on inside the duodenum. It just looks not very happy in there. You okay up front, Dee?
Yeah, I just need the velvet rerouted.
Okay. Can I get some 3O PDS, please? Do you need somebody to come in and help?
I think we need. Well, that's not working right now, but that's. Are we going to keep publishing some true PDFs? Yes,
Yes, please.
Mine, Ryan? I'm just gonna have to move this pad real quick.
Some closing mucosa and submucosa to start with. Alright, so now instead of that, or in addition to that, hold on to that, please. So we'll have to start this dog on misoprostol if we've got it. and probably pantoprazole. And keep a bit of tension on that for me, please. So I always do simple continuous in the intestine, but it's important to remember that you have to maintain tension on your suture the whole time to make sure that it's not loose.
But how do you remain the tension if you just don't have an assistant?
You have to have an assistant.
Okay.
So I always say, I'm a good surgeon and I can't do it without an assistant, so
Yeah.
if you're, like you really need, train a nurse to assist or whatever it takes, but you've got to have help for something like this. Nurses love scrubbing in. Pull that down like that a little bit. Okay, so let's have a look at this now. Now I'm thinking about doing a serosal patch on top of this closure that I've done. So just lift that up a little bit more. Probably grab onto it with that. Yeah. Can I get a loop of intestine up there that's loose enough Alright, so what I'm doing is I'm going to do a patch with serosa from another loop of bowel, because I'm not very happy with the integrity of my repair. So the way that I'm going to do that is I'm going to take a bite here. And take a bite to my loop of bowel. Now that has to be pulled up a little bit higher.
Yep, higher.
Just back.
Just back, yep.
Triage reception.
So basically I'm trying to make a watertight seal to the edges of my incision. Can you lift up on that for me, please? So I'm pretty happy with that. So I've done basically a side-to-side patch. So that looks really good. All right, so now we can put all the guts back in. So yes, there is, I guess, a potential risk that we could trap bacteria in there, but the risk is higher that, like, I've never heard of that happening before. So I think the risk is higher not doing it than by doing it. Can we get some warm saline, please? That abdomen actually does not look as bad as some that I've seen. Four?
1, 2, 3, 4, 5. And then another 4.
We've got 4, 5.
Yeah,
Yep.
sure. I got all the 12.
Is that warm? Can you suction for me, please? Can we get some more warm saline, please? I wouldn't worry about diluting out the albumin in the abdomen, because what you're really concerned about is the albumin that's in the blood, you know, in the plasma, not what's physically in the abdomen. Go ahead and pour that in, please. Get some OPDS, please. Go ahead and pour that in. Okay. Yeah. Thanks. You've changed. Prefer the British accent over the American accent in here, I think. I can say that because I'm American. So.
Yeah.
Much more sophisticated sounding, the British accent.
There's nothing sophisticated about Americans.
Nothing? No.
As a fellow American.
Yeah.
Nobody knows now.
Have you heard the Americans at the Ryder Cup in the golf? See how handy that is with the 2 suction bottles. It just goes from one right into the other. See, look at that, John. And you've got just tons and tons of space. We did, yeah. There's a lot in there to start with, but we have lavaged it and added some more.
Is this yellow list of all this imported omentum?
It's just kind of inflamed.
Inflamed fat.
Yeah, we can cut that off. Oh, can we get the ligature plugged in, please? And we need to put the ligature charge on this patient as well. Yes, the large vessel sealing. Yep, it's great. Yeah, it's automatic. No. We'll need a stapler, please. Skin stapler, yeah. Just use the smaller needle drivers here. Because these are really delicate, and so if you use the delicate ones, you'll spring the. Go ahead and take out that balfour. How's the blood pressure going? Good?
Breathing again. We'll get on the droplet.
Thank you. We'll cut both of these because I'm just worried that I scored it, so we'll go ahead and cut both and I'll do another one. Okay, and cut that one, leave it quite long. Thank you. So this, we didn't actually pre-med this dog. It was on a fentanyl ketamine lignocaine CRI, and so then we just anesthetized it with Alfax, and then we've put it on a fentanyl CRI during the surgery. We also have it on noradrenaline, antibiotics. We've been doing coags. The coags have been basically normal. It has been hypoglycemic, and so we have it on glucose. Can I get some 2O PDS, please? Not sure exactly what's going on. We had been pretty slow for the past like 3 months, and then suddenly it's just going crazy. It's coming into spring. I think Australians just hibernate over the winter. Suddenly everybody remembers that they've got a dog. They've been watching Australian rules football, sitting on the sofa, and the owners and the dogs have just been lazy, and then suddenly football season's over and everybody remembers that they've got a dog and that they have to exercise, and all of a sudden everybody comes out of the woodwork. So I've seen a bunch of cases of perforated duodenal ulcers on non-steroidals. I've probably seen 6.
Oh wow. I've only seen one, maybe.
You've seen one?
Yeah.
Yeah.
But never like this angry, yeah. But when you do the serosal patch, even though the other section of the intestine looks angry, can you still do
Yeah,
that?
yeah.
Right.
It's just inflamed, but it's not devitalized or anything.
So it doesn't really need to pick out the healthy one?
Not necessarily. No, I mean, that was not, like, it wouldn't, if it was necrotic, we'd be resecting it. It was just inflamed. And that was the most mobile, so I'd rather use a mobile one that's inflamed than one that's not particularly mobile and then run into problems because we've got it under too much tension.
Plasma's finally running.
Hey?
Plasma's finally running. We're running the plasma now.
I can't understand what you said.
Plasma's running.
Plasma is running. You mumble worse than I do, Dee.
I think your ears are worse. Well, because we still have the suction on, so it's pretty noisy.
Yeah. Oh, we can turn off the suction now, by the way.
Thank you.
Thank you. Yeah, so it does have, it is on a noradrenaline CRI. It's probably up to about 15 mics per kilogram per hour. Do you know exactly what it's on, D?
Triage to reception, triage to reception.
40 mics per ml and 50 mils an hour, so 50 kilos.
You expect me to do that in my head?
Are you reading it? But it's 50 times 50, right? So it's 40 mics per mil and 50 mils an hour for 50 mil. 50 patient?
So it's 40 times 50 divided by 50.
Yeah, right.
So it's just 40.
Yeah, I thought you could do that in your head, but
Yeah, I could. Once I thought about it. So it's on 40 mics per kilo per hour, which is quite a high dose. We used to do only like 5 to 10. Because once you got above that, then you started getting peripheral vasoconstriction and not just myocardial contractility. But I think they've changed those guidelines now. So hopefully we won't go into DIC overnight or SIRS. You heading out, Tiana?
yeah.
Thank you very much.
Thanks for today. I'll see you. Oh, I'm not here tomorrow.
Okay, see you next week.
See you next time. Yeah.
Send our best wishes to Mia.
I will.
Thank you. I sent her a note on WhatsApp, but I'm not sure anybody reads it.
I actually read it.
Okay.
I saw it.
Oh,
So I don't know if anyone else reads it, but
you did? Okay.
which one?
Did you read it?
I didn't. I'm not in a group.
Oh, well, you should be. That's where I tell all my jokes.
Oh yeah, admin me.
Yep. Yeah, we will not have this dog NPO, and in fact, we're going to put in an esophagostomy tube before it wakes up. We want this dog eating straight away, and we did not put in a Jackson trap for drainage because the peritonitis was not that bad. Alright, so now we need to get a nice long right angle forceps to do a... So we'll just get him on his side and shave his left neck. And I will come over and make sure I answer all the questions. So I tend not to do open peritoneal lavage unless it's absolutely necessary. No melena in this dog. We'll give antibiotics for probably a week. You could do a resection and anastomosis, but in that area it's really hard because of the common bile duct that's coming into that area, and so it would be very challenging to do a resection and anastomosis. We could not diagnose perforating a duodenal ulcer on ultrasound. It's too small. That was only probably 5 millimeters long. So the segment for the serosal patch, it was very inflamed, but it was still very viable, so it'll bring in growth factors and create the seal. A mental patch does not do as good a job at sealing the intestine as a serosal patch. We have started plasma. Our empirical choice is cefazolin and enrofloxacin. And I apologize for the lack of volume. All right, so anyway, if you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live.